So as we learn to hold the pelvis, we're holding the pelvis in our hand so that we have our index finger and thumb in the opening, and we've tipped the pelvis forward like a gateway. We remember from our Spinning Babies workshop that the ASIS is in a vertical line to the symphysis, and so that this is the standing person. The baby is coming around from the front and often from the left. So I'm going to demonstrate this from a left occiput transverse position, LOT. And the baby starts to settle low over the pelvis at the end of pregnancy, oxforn. So in general, most of the babies are in their birthing position, and we're finding that the baby on the left is waiting there, and as approaching 38 weeks, 30 to 39 weeks, many of the first-time babies are dipping into the pelvis and starting to engage. The baby could be like this for a couple of weeks before labor starts. Just because the baby's in the position doesn't mean labor's ready to start, so the baby is maturing, the signals are going between the baby and the birth giver, and they're getting ready for the onset of labor. And at the onset of labor, contractions begin mildly, start to get longer, start to get stronger and more frequent. And we're going to say that this person is about to be assessed. So maybe they go to the hospital to triage, and the midwife or nurse checks the cervix to see what's going on. And for the sake of our discussion on the progress of a normal labor, the nurse might find you 3 centimeters dilated. I'm going to start saying you because otherwise I'm going to teach providers instead of parents. So that's what I'm going to do. And often, if the nurse is able to feel the sutures of the baby's head or the seams between the skull plates near the soft spot in the front and the soft spot in the back, this little seam is a nice indicator of where your baby's facing. And though the nurse can't always find it,
I think the water is
don't even worry about the details. Just let me get through this. So that when the baby is coming down, if the nurse were able to feel the sutures, the nurse or midwife might find the baby facing your right hip, the back of the baby's head on your left side. As the very first check happens, those sutures might be near the front of the pelvis. So the sagittal suture would be side to side, close to the front of your pelvis with a lot of room in the back, telling the nurse that the baby is just starting to come into the pelvis. The hospital in our town wouldn't admit you yet, so they would say, why don't you take a walk and come back? So let's say you take a walk through the halls, or if it's a nice day, to the park, and you come back, and now the nurse finds that your cervix is still 3 centimeters. But there's been a lot of progress that your baby's been doing, and your baby's sutures are now found in the back of the pelvis, a little bit further back. And that's really good news because the baby has come in and turned under the bone in the back of the pelvis to come fully into your pelvis and engage. The baby's still going to get a little bit lower, and when the baby comes lower, those sutures will be side to side. And so these are some of the things that nurses, midwives, and doctors can notice to show them how well you're progressing in labor. And about the time that the head is down so that the sagittal suture is going side to side, the cervix might have responded by opening up to about 5 centimeters. Contractions are strong and frequent, about 60, 75 seconds, probably they've probably been 75 seconds, even 90 seconds for a couple of hours by this time. moving this, I don't know, probably wouldn't say a couple of hours to tell you the truth. I need to watch a real pregnant person. Because that keeps me away from certain things. In your mind, the birth hormones are getting busy and releasing endorphins. It can be like a runner who's been running and finds that wall where their muscles are burning and they have to really focus, and it's a time where some runners might give up and might even say something in their mind like, if I get to a stop light at that corner, I'm stopping. But they notice that if that light's green and they keep going, that they have to focus on their breath and they change their rhythm. And in birth we talk about relaxation, rhythm, and ritual. And that simply means to go into the sensations your body's teaching you, find that relaxation with your breath, and using your rhythmical breath to find a ritual, which might be an image, it might be something you're looking at, it might be a movement, it might be a verbalization. And it really helps you cope as your brain releases endorphins into your body. And that takes the edge off. It's your natural relief in labor. And it gets very active in your brain at about this time as the baby's coming down onto the pelvic floor. The pelvic floor is open front to back, and as the baby's, I would go this way, as the baby's head comes into the pelvic floor, the little corner in the back of the baby's head is pushed into the pelvic floor opening, which then turns the baby. So that just before transition time, the baby is now finding the space deep in the pelvis where it's open in an oblique diameter. It's open in the diagonal space. It's like the baby's playing peekaboo through the sciatic notch, through that little window in the pelvis. And we often find the baby there at about 7 centimeters. As the baby goes lower and the cervix goes more open, that's the transition between dilation and descent. So that's why it's called transition. And contractions are quite close together. As your body opens to 8 centimeters and more, the baby is starting to come to face the back. And the back of the head is fitting through this arch in the front. And the baby's soft face is near the coccyx and the sacrum. And there's often a little space there in the back. This coccyx doesn't open like a door, but this door is opening as the baby comes down and below. And now when the cervix opens up all the way, sometimes there's a rest and be thankful period. And your contractions might suddenly get a little bit more spaced apart. It might only be 5 minutes, so you might miss it. But it might be a little longer. And this is allowing the ligaments to adjust to the baby's depth in the pelvis. The cervix has moved out of the baby's way at the end, and the baby comes down into the vagina. And when that happens, the fundus at the top of the uterus, the top part of the uterus, may need to catch up with the baby. There might be a little space now. Instead of pressing directly on the baby's bum, the top of the uterus is a little above it. And so for a few contractions, they're a little bit more spaced out. You don't have an urge to push if you get this rest and be thankful period, which not everybody does. But once the fundus catches up with the baby again and starts to move the baby down, the urge to push establishes. This baby needs to have its hands here. Kick it through the pelvis. Then we went through a quiet time in second stage while we were in that rest period. And when the second stage gets active again, and you get the urge to push, the baby starts to move down. You take a few contractions to get the sense of what your body's doing differently this time. And it's a natural time to get used to second stage and to get a sense of what your body wants to do. Some people get an urge to push and it takes over their body, and other people have a gradual approach into that urge to push. As the baby comes down into the perineum thins just like the cervix did before it dilates, just like the cervix thinned before it dilated. And you'll see the baby rock down and back as it prepares the perineum to stretch open the baby's head. But this gives the baby a little breathing time too with the umbilical cord. So it's a totally expected and useful time to have the baby rock back and forth. As the perineum sweeps over the baby's parietal bones, the baby starts to arch its back in extension. And extension is another of the cardinal movements. And this helps bring the baby through the perineum. The baby's head can stay flexed even while the back arches in extension. When the baby's face comes through the perineum, there's also another rest time now. The chest is now in that buttonhole opening of the pelvic floor, and either right away or waiting until the next contraction, the chest will turn in the pelvic floor and we'll see the baby turn a little bit on the outside. That's called restitution, and when we watch for that, we know the chest is turning in the pelvic floor. And that's reassuring to see that, and it's beautiful to see. When the shoulder comes up below the bony pelvis and the chest is lined up with the pelvic floor, we'll see the baby face the hip on the same side the baby started with. So if the baby started on the left, we most usually see the baby end on the left. So the baby starts in the finishing position, just like you did with forward leading inversion. Now, the baby sometimes comes out all in one contraction, and sometimes the head comes out and then the body comes out, and sometimes that pause seems a little bit surprising because we're expecting, we breathe air, and we're expecting to see breathing right away, but the baby, remember, is breathing through the umbilical cord. So this pause has been shown in recent science to be fine for the baby to go through. And your provider will have a habit about helping the baby out at this time. So when nature is in the habit of helping the baby out, we see that that front shoulder is held back by the non-stretchy tissue that supports the clitoris and the urethra. But the back shoulder has room to swoop through that curvicaris. So the posterior arm, when not snapped together with the first one, often is born first. And then the front shoulder, the anterior shoulder, is born second. The hips come through the pelvic floor and the baby rotates. And if the baby is not being helped out by the provider, the baby often turns towards the birth giver. So the mother can then, if choosing, reach down, take the baby, and bring the baby up. Skin to skin. Now the baby is connected to the umbilical cord yet. And so there's this little in-between worlds moment as the baby arrives in the shades of color that keep the blood near the head and the heart. And as the baby is on the chest and testing to see what's out there, is it air, is it milk, is it water, to know what to do. And if it's air, you know, as the baby is coming out this way, they're often spitting out mucus, but if they still have a little water or mucus, they will wait. And so when we see a baby horizontal like that, they're sometimes waiting. Yeah. And there is a time where we put them on the safety position so they can spit that out. But if they remain waiting, they'll test and go, okay, it's not air, so I'm not going to inhale it, so I need to clear my throat. And they're very competent about doing that when they've had a easier birth, and so as they're doing that, what's going on in you, or what's going on in the person that is just giving birth? They've been right in their center, in their core, and these hands are not typically part of their awareness, right? So it takes a little bit to become aware of your hands, and you're watching the baby. The baby's sputtering. Their baby's beautiful. The mother strokes the baby with a hand and then comes back, touches and then retreats. This has been studied when there's not interference. Very often at this time, we might see, if we're observing a birth like that, a turn towards the person that's been helping and say, is my baby all right? And we often turn their attention to the baby. Talk to your baby. And that's a very special redirection back to the mama toto to keep that circle intact. And the instincts often descend, and the mother then reaches down, lifts the baby to themselves. Often with a sigh, and when we hear a baby cry out, we'll watch. Sometimes the baby's crying because they're spitting out, they're taking in the oxygen, they're like, what just happened here? And they need a big breath to get that first breath in. Big breath for a baby is not a big breath for an adult, so don't get that confused. It's about the amount of air in your puffed cheeks. That's it. So the baby, once they've cried out and they've filled their oxygen up, and some do that quietly, is there. But when the placenta comes off of the uterus, you see the uterus is shrinking down and it becomes smaller than the size of the placenta, so then the placenta comes free like ripe fruit off a tree. And the baby in this quiet birth cries out, ah! And when I hear the baby do that, ah! Then I watch and I see the trickle of blood that indicates the placenta's released. Because the baby knows, even if the cord is not pulsing anymore, because the baby's gotten its blood back from the placenta, that blood coming back from the placenta is happening right away and taking place, most of it's already back to the baby in the first minute, even if it pulses longer than that. And so the baby in that first minute has made quite a lot of transition time. Started breathing, the colors are changing so that the blood is showing more evenly throughout the body. And then this happens later. So now the baby is very interested in where they are. They hear the heartbeat, they feel the warmth. Their hand sometimes goes to the nipple. Where's the mouth? Let me be reassured by what I know. I know my fingers. My mouth is so full of nerves that I'm learning my whole environment through my hand. So the pediatrician Marshall Cuss has asked us not to dry the baby's hands so that they can get the amniotic fluid to the nipple, to their mouth, to the nipple, to their mouth. And this makes the nipple especially interesting to the baby because they have both the familiar and the novel. They have the visual signal of the areola and the smell of the tubercles, and in time, babies have been observed to self-attach. And they're in this vertical position. But we have a checklist to go through. We have time element on our hand. We want to be helpful. We want to make sure this breastfeeding happens. We often turn the baby to the side and do as we're told, to take that breast like a hamburger and put it in the baby's mouth. And if that's not immediately working, we might get more helpful and pop bead the baby to the nipple. Anybody still seen that in their facilities?
What's it called?
Oh, I call it a pop bead. You know those bright colored plastic beads that toddlers play with, and there's a little bump on one side and a hole in the other, and you pop them together? You know?
Yeah.
You don't know? You know those
I
toddler
know what you're
toys?
talking about.
You make a chain. You
Oh,
gotta
yes,
go to
yes,
the dollar
yes,
store,
okay.
right? So
we're gonna feed the baby to the nipple like it's, right? Let's get this baby trained in the mechanical operations of the human body before, no, oh, wait a minute, that's not our paradigm. That goes on a not spinning baby's paradigm, not feeding them. And we start to see this.
Yes.
Yes. I don't know. I mean, I was 17. I came from a family that said, you know, no farting, pooping, you know, nothing happens below your neck, right? So now I'm trying to breastfeed my child, and I think, oh my God, I've got my bare breast out, and this kid doesn't like it. Right? Have you ever helped somebody who thinks, oh, my baby either is embarrassed about my breast, doesn't like my milk, there's nothing there, there's people in the room, and it all falls apart. But the baby is saying, I just pushed my head onto a cervix and opened it up, and if you've got another thing, because I can feel something there, I can open that up too. I'm very confident. I have a dilation instinct, so I wanna open up what's on the back of my head. So if your hand is there, I'll open it up. Watch me. Did I explain that right? Maybe a little klutzy. But they have an instinct to put pressure with their head. And now we've given them something to use their instinct, their reflex.
That's what it is. Back.
Does that include
The hat?
you know, when you're putting it on, but I don't know, but yeah, that's a good question. So we have these social things that we try to help babies, the hat, the holding them sideways, the care that we do to not just be efficient, but to be careful, to help this vulnerable little person. And what's happened is we've based our help for babies on a few decades of anesthesia and institutionalized birth that wasn't human-centered, right? It wasn't family-centered, it definitely wasn't woman-centered. And so we have a lot of habits that have bypassed physiology, the heavy anesthesia, the heavy use of instrumentation. So we thought that babies were blind and dumb in the 1950s, all the way into the 70s, you know, because the research from the 60s didn't get there until the 90s. And so now we know that's not true, and the baby can see 50 feet, but sees very well from breast to eyes, this distance, in full color, but likes dark edges, so black and white's popular. But just because there's a bunch of toys in black and white doesn't mean babies don't see color. They just like the edges, right? What is that out there? So we be mindful to talk about birth in such a way that doesn't make a person or a profession or a location of birth the bad guys.
Say that again.
We be careful in the words we choose to not have a location in birth. Oh, you're taking pictures and I'm all kitty wampus.
No, I'm also just moving you right.
If we do physiology before force, then there's no place in physiology for a bad or good. Bad or good or force terminology. That's a force terminology. So the idea that natural birth is good and interventions are bad, midwives are good, doctors are bad, home birth is good, hospital birth is bad, that has no place in physiology. What we have a place for is where are we in our body right now and what serves us. And there's a whole bunch of variation out there because there's a whole bunch of variation in here. And so we pick our words to describe birth, which I don't think I did a stellar job today, but it was okay. But you can see if you took a little bit more time that you could weave it in. You might do it in parts with pictures first, then movies, and do it in different parts, and then weave it together with the story of the baby moving through the pelvis. And we want to talk about our story of the baby moving through the pelvis in a way that is baby-led and anatomy inspired, right? And that brings them back to why do we prepare, and then gives them a little reward about how alert and aware and what the baby's thinking about. And I gave you one example, but you might have more. You know, and when we talk, and we end in the skin to skin, because real purpose of spinning babies is why have an easier birth with less pain? So that there's more intact mama toto. So this ability for the baby to be skin to skin with their parent, with their mother, sometimes it's a birthing father, they have this connection. This is the time that we have prepared for. Not a moment ago where I was pushing the baby out. That's a good side effect. That's a good extra bonus. But it's how we feed our babies and how we bond with our babies. So we're going for attachment and bonding. That's the purpose of spinning babies, is our having intact attachment and bonding. Why do we want intact attachment and bonding? Because therein lies the future of humanity. And we have a sensitive period of pregnancy and birth where parents are absorbing, and when we say to the other parent, your baby knows your voice, and it's going to be so rewarding to see the baby look at you when the baby recognizes your face to match this voice that they know if the other parent lives in the home. You know, they have that to excite them and to help add communication moments with the baby. Go to the warmer and talk to the baby, or, you know, gives them motivation to hang out with their baby longer and not give in to, well, it's time to weigh your baby, or I'm the grandma, I want to hold the baby, or, you know, all my friends are here and they want to hold the baby. You know, it's like, okay, you get to hold the baby, but right now we're not finished with 4th stage of labor. So those are things that you've worked out in your childbirth classes, but while they're not necessarily something that you're going to spend much time on in the Spinning Babies module, they are things that you're thinking about and weaving in what is physiological in afterbirth. So let's review the cardinal motions.
So before you do that, if everybody, for your textbooks, if you open it to page 64, then you can follow the cardinal movements through as Gail's doing them, so that's helpful.
Because I realized I just did this story without looking at my list. Okay.
You have this thing about knowing how the baby moves through the pelvis. You developed a whole thing called spinning babies around the baby's rotation through the pelvis. I'm pretty sure you know it.
But, you know, I still feel like I don't know and I was shy about it. Okay, so engagement. Most babies engage before labor, about some engage during labor, and we have a few tips to make that easier. So engagement is when the head is 3/5 of the way down. There's 2/5 of the head above the brim. You usually see the shoulder at the brim, but when you show 2 fingers above the brim, it makes the shoulder look like it's way above the brim, but that's not the case. Because babies are not vertical out like this. There's a lumbar spine that brings them around, curls them up, and puts the shoulder in front of the pubic bone.
I'm sorry, Gail. 3/5 or 4/5, just for consistency.
3/5 down. Why
It says
does
4/5
say
in
4/5?
here.
And
Oh.
in the parent class.
Okay, 4/5.
Okay. I just want to be sure that I'm saying the same thing that.
Where?
We'll look it up. If the baby's head was 3/5, I'd be happy as a midwife. Descent. Now descent is our second cardinal movement. So the baby comes down, and as the baby comes down, it flexes more. So it's not that it wasn't flexed before, it flexes more, okay? And then internal rotation. Where does internal rotation take place? Through the pelvic floor. It's the pelvic floor that leads the rotation of the baby. What part of the baby's head is the leader of rotation? The parietal eminence. Actually, your left parietal eminence with this baby. And then, so that's number 4. Number 5, oh, there's a continue. Number 4B is continual rotation until the baby's low in the pelvis, coming out the outlet in OA. So if OA, occiput anterior, was the optimal fetal position, a lot of these babies, we wouldn't see that until just before transition or during transition, sometimes even at 10 centimeters. So that is a misnomer. And if you read Jean Sutton's optimal fetal positioning, she doesn't say OA is the only optimal position. She indeed says LOT is the most common starting position. But this is the most common ending position. And that's why, because the baby has to rotate through the pelvis. So now when the baby's head is on the perineum, the back has extended to put the shoulders into the brim. So the baby is going to make this little wiggle movement to get the next body part into the brim. And extension brings the shoulders in, and it has the head emerge. And then 6 is supposed to have bold where it says restitution. Restitution is caused by the pelvic floor and the chest turning to, the chest turns to fit the puzzle piece shape of the pelvic floor. All right, the front to back opening of the buttonhole of the pelvic floor. The chest being thinner front to back and wider side to side makes it turn. So now we have restitution. Restitution, it's okay for the head to rest there for a contraction, and it's okay if it doesn't. And then expulsion is, or emergence, if you want a more gentle word, is when the shoulders and body are born. And then the last cardinal movement is chest to chest. If skin to skin, I should say. Depends on the length of the cord. So those are the 1, 2. So if I have my hand here, I can guide this head. 1, watch the ears, because they're the buggers. Bring the ears into the pelvis. Okay, the childbirth educators, cardinal movements. Number 1, ears in the pelvis. Number 2, the whole head in the pelvis down to the ischial spines. So put your finger on the ischial spines. Bring the head that far. That's descent. It's at that level that the baby rotates. So keep the baby inside the tuberosities to go first to the oblique and say this is where we see the baby when the baby's coming into transition and moving through the mid-pelvis. When the baby gets quite low in the pelvis, we see this baby turn to face the tailbone. Once the baby faces the tailbone, there can be a rest and be thankful period as the cervix gets fully dilated, and as the baby comes down and starts to come, the head starts to come through the perineum, we see the head. They do the extension, drop their shoulders into the pelvis, the pelvic floor turns the chest for restitution. Right, so we try to keep the arms up into the pelvis, but you know, you see that sometimes that's not happening, right? Posterior arm first, anterior arm second, chest and hips through the pelvic floor, baby turns towards you, comes to your toe. it's real, if you can get really good at it, you can put the placenta under your shirt and have the umbilical cord connected and model keeping the cord intact. And I need a big header on the notes to have the placenta. And also the other thing I forget is at 8 centimeters, when the head has turned to the oblique, when the head is in the oblique, I want to remember to say at about 8 centimeters, the birthing person gets a jolt of adrenaline, or gets a little release of adrenaline from their brain to get into an upright position. It gives them an urge to get up. I want to get up. Or I have to get up and go to the bathroom, right? You know, you're getting some descent, some rotation, some adrenaline. They've gotten over the sleepy oxytocin phase and are now into the adrenaline phase. And that is for the purpose of vertical birth. Okay, extension and restitution and expulsion. So now you're gonna play with it. Now that's that's regular. I want you to play with that, but let's talk about what happens on page 65 for the ROP baby. When the ROP baby starts labor this way, if the baby drops into the pelvis in this direction, the descent happens often with less flexion. And so the number 3, flexion, is if they have some flexion, they may be more likely to be born vaginally than if there's no flexion at all. And if then internal rotation may not be able to may go to the short arc rotation, where they come to the posterior to get past the ischial spines. That would be through the pelvic floor. And now they can't rotate here because the tuberosities are stopping them from rotation because of these wide parietal eminences. So sometimes the posterior baby comes down and you see the hair. You might now see rotation because the head is now south of the tuberosities, but just still at the perineum. So there's quite a bit of space between the bones and the opening of the perineum. And if that, and it varies with different people and different sized babies, of course. And so now we have this baby is coming posterior. And so this wide part of the head is into the perineum. Right? And now in this one, in number 4, this is a short arc rotation. I showed you short arc rotation. Wait a minute. Oh, that's on page 67. So long arc rotation usually happens. Long arc rotation means the baby starts ROP and rotates around to LOT. And once the baby rotates around LOT, we have a labor that's much more similar to the LOT baby. Flexion might be slightly different. And it might take a little longer because the uterus might be tired by the time the baby's there. But most of the work is turning. If we can turn above the pelvis, we can get over to either ROA or LOT to drop into the pelvis.
Is it rotating around the front or around the back?
I believe they rotate around the front.
That's like mind-boggling.
And
Because for 30 years, all I've learned was it rotated on the back.
Yeah, that's
Yeah,
what
I
I'm
know. In 2003, Penny and I had a little, let's go to the side of the room and whisper about this. And she says she sees them go to the front. And with the fetoscope, I would track them going. And in the fetoscope, you see the little circles following them around. Yeah. And it, there are books, like I had 40 midwives in Australia, and they're like, no, Gail, that's not reality.
And I said, well, maybe it's south of the equator. You know, water's supposed to go the other way down the drain. Maybe babies rotate the other way. So there was a discussion. I said, this is what I observed. Do you observe the circles? Yes, they do. Do you observe such and such? Yes, they do. But I know one baby turned this way. Okay, I know one baby turned that way too, but one baby doesn't make, when 99 babies are going this way, or whatever the number is,
Then the-
actually it'd be 999 for most of those women.
So the explanation from the providers in the hospital that you're feeling the back labor because the baby's head is against your spine.
No, we're feeling the back labor because the muscles, nerves, and ligaments are all jacked up.
All jacked up because you've got this baby's
And
head trying to go.
Secondary, we might do it because of the bone, the pressure in the
Right,
bones.
okay.
Because we do know when the baby turns, our back labor goes down. But we also know when we do forward leaning inversion, the back pain goes away.
Yeah.
You're saying that it's the jacked up muscles that cause the back pain, nothing to do really with the baby's head being there.
And the jaw.
Because it's.
You know, this is definitely a chicken and the egg thing. So there,
Because the baby's head is there.
when the baby rotates, you get less pain, but you also get that pain when it's jacked up. So let's, instead of focusing on trying to turn the baby, let's focus on trying to
Focus on
relieve
making her-
the muscles. And then the baby will say, thanks for getting that really tight posterior area. Right flank, that whole right flank out of my way, now I can rotate. And so, I just want you to know, ROP is the classic posterior position. Most of the posteriors are gonna be in this position. Short arc rotation means it goes posterior to the front. Half of those babies can be born vaginally, half by cesarean, approximately half. In a university setting. Long arc rotation is ROP over to ROA, and then to OA, and then this baby restitutes to ROT. If this baby can make it, I don't see a ton of babies being born that way, but that's in the literature. I usually see the ROP babies either going to OP or going up, around to the left. That's what I see. ROA is not that unusual, but it's not the only way to do it. But that's what's in the books. I want you to know what's in the books, and I want you to know why I don't always
But they
agree.
turn over the front and not over the back. So that's.
Well, what's in the back, darling? This ligament, this lumbar spine
Yeah.
is right here. Why would you turn into a lumbar spine?
So that means they turn counterclockwise.
It depends on if you're looking from the top or looking from the bottom. I never understood that. I thought that
But
they're
if I look
turning
from
clockwise.
From the mother's side, then this would be
Oh.
counterclockwise.
If I'm looking up, the
No,
baby,
but
the
if-
occiput was here in ROP, it goes over here. That's clockwise.
But from the mother's perspective,
So
it's
that's
counterclockwise.
Yeah, and so these 40 midwives in New Zealand, they all said I was crazy. So then I went back to the home of one of them, and she got out her textbooks, and the graph in the textbooks said, here's a 135-degree turn, and here's a 90-degree turn. But the arrow went from one number to the other number, and they assumed that it meant that the baby went past the vertebrae because of how the thing was drawn. And I said, let's look at that, and let's read the text. And the text said the baby turned around the front. But the picture, the way the graph was drawn, people were thinking that the baby went right, in fact, the line went right through the vertebrae. Now, I know those midwives didn't think that the baby went right through the vertebrae. It was just how the graft was drawn and how it's been taught in New Zealand and Australia. And then the midwives went, bing, 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 that's what I see, but this is what I've been taught.
Isn't dextrorotation the
Dextrorotation.
explanation that you get?
That's our Western explanation.
Yeah,
It's not
that
accepted around the world.
Everything in the body moves in a clockwise
Yeah.
position, and the uterine muscles, the way that they're aligned on the diagonal.
Well, different muscle layers might have different directions, but I like that I like that explanation because that's what I see.
I know for
Makes
me,
sense.
from what I was taught, it meant that if your baby starts ROA, they're gonna go posterior, and then eventually,
Yeah,
if the
that's
mom
the way
doesn't
I
get
learned.
too tired,
But
and
that's not-
everything- then
yeah.
the baby comes out,
No,
goes
that's
into
not
LOT.
correct. Most of the explanations for how babies come out are not, first of all, none of them are universal, whether, babies don't all follow the exact same path. But many babies follow the similar paths. And there's really for an OP baby, the classic beginning of that is ROP. So the ROP baby is the baby that's more likely to rotate. The direct OP baby is more likely to go through OP, but could rotate. So ROP has short arc rotation to OP, long arc rotation to ROA, or start over rotation to LOT. There, got it out of my